Welcome back to the Rebel Core Content Podcast. Core content for anyone, anywhere, and just in time. This is Swami, and we are once again this week dipping into the Only in Staten Podcast trove of treasure, the fantastic podcast that we have over there. This one is about cardiogenic shock, and there are some references to our cardiogenic shock team. I left that all in there because even though that is something specific to our institution, we are seeing these pop up in more and more places. And I think it's something to consider adding to your particular hospital, or at least adding the skill set that that team can bring to the bedside. There's a lot of great information here from the lead of that team at our hospital of how to identify this group of patients and how to best take care of them. So we left it here in full. It won't all apply to everybody out there, but I think there's still a lot to take home. Welcome back to another Only in Staten podcast. This is Swami, and today I'm here with Dr. Martin Amor, who is a critical care cardiologist and the director of the CCU here at Staten Island University Hospital. Welcome to the podcast, Martin.
Thank you, Swami. It's good to be here, and thanks for inviting me to speak about a topic that's very close to my heart. I've been in Staten Island now for a year, and talking about cardiogenic shock and shock teams has been one of the fundamental directives that was given to me when I joined SIUH last year.
Great. Well, let's get right into the topic since you're telling everybody what we're going to be talking about. I think cardiogenic shock is a really important topic for us to look at in emergency medicine. And the problems begin right at the start with identification. When we see shocky patients, most of us jump to sepsis and then have to work our way back. And cardiogenic shock can often be mistaken. We can often think it's sepsis, but actually what we're dealing with is cardiogenic shock. We have the cardiogenic shock team activation protocol. For us in the ED, what should be triggering us to say we are dealing with cardiogenic shock and I'm going to activate that team to help me out?
Before we go into the signs of cardiogenic shock, I think it would be worthwhile to define cardiogenic shock. So loosely defined, cardiogenic shock is any cardiac disorder that results in any biochemical and clinical evidence of end organ hypoperfusion. So for this purpose, the things that we should be looking for to cue us into cardiogenic shock are the following. So the first is hypotension. We define that as systolic blood pressure less than 90 millimeters mercury for greater than 30 minutes, or the use of inotropes or vasopressor agents for hemodynamic support. The other signs of end organ hyperperfusion include decreased urine output, elevated BUN and creatinine, elevated liver function tests, altered mental status, cool extremities, tachycardia, etc. And lastly, for other objective blood tests, you could look for a lactic acid level that's elevated more than 2 millimoles per liter. Take note that these do not all have to be present. Sometimes only some of these are present. And in fact, some people even have normal blood pressure or even high blood pressure when they have cardiogenic shock. The key is to find evidence of end organ hypoperfusion, and left alone to their own without any intervention, these people with normal blood pressure in the early stages of cardiogenic shock will eventually go into the hypotensive variants of cardiogenic shock.
It is all about that early recognition. So the patient who comes in whose blood pressure is soft or even normal, and we're looking really for those signs of hypoperfusion. It's not about the pressure, it's about the perfusion. And one of the things you mentioned is really important in the emergency department management and identification is the cool skin. In sepsis, the skin typically is on the warmer side because they're vasodilated. In cardiogenic shock, they're going to have cooler extremities, and that might be our only initial tip that we are looking at cardiogenic shock as opposed to septic shock, or that there's some combination of those. So feeling skin is really important. Sometimes that physical exam skill gets lost, but this is critically important. The other thing that we kind of rely on, because some of these labs are going to take a little while to come back, the extra information, but bedside echo can be extremely powerful when we are trying to identify those patients with cardiogenic shock. But lots of these patients have a poor EF at baseline. Now they're coming in with a worsening. How do I use my ultrasound to identify those cases of cardiogenic shock?
So what we usually do in the echocardiogram is we need to use Doppler principles to figure out if the stroke volume and consequently the cardiac output of the patient is low, to tell whether we are in a state of cardiogenic shock or not. The crucial view that we need to obtain in this process is usually an apical 5-chamber view, which involves a view so that we could open up an area in the heart called the left ventricular outflow tract. So the left ventricular outflow tract is the area where ejection of blood comes out of the heart. And if we are able to use Doppler to capture a specific point in the left ventricular outflow tract, we are able to measure using hemodynamic principles the the flow to the LVOT, which is consequently the stroke volume of the left ventricle. And this Doppler measurement that we do in this situation is a measurement called the left ventricular outflow tract velocity time integral, or VTI.
Of course, it's really hard to explain on a podcast, audio only, how to do the ultrasound. So we'll drop a link on how to get that LVOT VTI. But Martin, once we can get those numbers, what are we looking for? What are the parameters that tell us that this patient is in cardiogenic shock, or at least that cardiogenic shock is more likely in that patient?
Assuming you've obtained a proper tracing of the left ventricular outflow tract, the VTI, the usual normal value in a patient with normal heart rate is usually around 20 centimeters. So if this value is reduced, like less than 10, then that should raise red flags in your head that the stroke volume is reduced. Thereafter, once you have this number, that should probably prompt you to call cardiology for further evaluation so that you could figure out if there's a big cardiogenic component to the shock that you're dealing with.
It's great. It's a good number for us to have in the back of our heads. And again, we are taking all of that in context of the overall patient. So we have that hypoperfusive state, we have that cool extremities, and we now have this ultrasound. All of that information together can trigger us to call our cardiogenic shock team to get them down to help us managing the patient. In the meantime, while I'm waiting for you and your team to come down, now that I've recognized the patient's in cardiogenic shock, what specific therapy should I be bringing to the bedside to help that patient?
So once you recognize cardiogenic shock, now we should recognize what medications should be started to this patient to improve perfusion. The medications that usually come to mind are either inotropic medications and vasopressor medications. And I think it is both an art and a science figuring out which among these medications you need to start first. The other thing that you need to bring to the situation is, what about the volume status of the patient? And do you need to bring diuretics to offload the end organs in this patient who is already showing signs of hypoperfusion?
The idea of giving the diuretics to these patients when their blood pressure is soft or even low gives everybody a little bit of angst. Why is there a benefit in this group of patients to actually diurese them, to getting some of that volume out?
I think that is the fundamental question, and one of the most frequent things that we get called about when we are facing these cases. So a lot of these patients with cardiogenic shock, they are congested in the lungs, they are congested in the liver, and congested in the kidneys. So technically, they are hypervolemic from a volume standpoint. And I was brought up by astute cardiologists back in the Philippines who always told me that if you give diuretics to a hypervolemic patient, you should not tank their blood pressure. However, in common clinical practice here in the United States, people are very hesitant to do this. So what usually needs to be done first so that people will be more comfortable to do this is we start the agent first to help forward flow. And this is why we start the inotropes to concurrently before we give the diuretic doses.
Let's talk a little bit about volume status, because that can be a little tricky here. We're talking about the fact that some of these patients are going to be volume overloaded. They're not all volume overloaded. Some of them have insensible losses that they've been getting sicker and sicker over a couple of days. So how do I assess the volume status of these patients? And then how does that trigger my decision to reach for either a diuretic or to actually reach for volume?
What I would usually advocate is to combine both clinical and echocardiographic or ultrasonographic measurements of volume status. So from a physical examination standpoint, you would hear crackles in the lungs or see leg swelling. However, the more objective clinical parameter based on physical examination would be neck vein distension. So we need to be able to assess neck vein distension and a maneuver called hepatojugular reflux to see if when we push on the liver, if we elicit massive distension of the neck veins. So that's as far as physical examination parameters. But if we wanted to objectively measure the volume status using ultrasound, one of the things that we need to look at will be the inferior vena cava on subcostal imaging with transthoracic echocardiogram. The parameter that we use is once we have either a static measurement of the IVC or a specific MO to the IVC, we try to look for the size of the IVC and the collapsibility of the IVC with inspiration or sniff. The cutoff value is 2.1 centimeters. And if the IVC is more than 2.1 centimeters and less than 50% collapsible, then we would estimate that the filling pressures or the central venous pressure of the patient is between 10 to 20 centimeters, compared to the other opposite where it's less than 2.1 centimeters and greater than 50% collapsible. The filling pressures are estimated to be 0 to 5 centimeters. Any other combination of those two parameters puts you in the in-between range. For the vast majority of these cardiogenic shock patients, they will be of the higher variant. So the IVC will be more than 2.1 centimeters, and it will be collapsing less than 50% of the time with sniff or deep inspiration.
And using the IVC can also be really helpful if you're not sure, is this cardiogenic shock? If you have a shocky patient, you're like, maybe this is sepsis. You look at the IVC, it's fat and plump. There's not a lot of respiratory variation. It doesn't mean it can't be sepsis, but it definitely pushes you a little bit away from that diagnosis towards cardiogenic shock. And again, we're combining all of these different parameters together to make that diagnosis. So we have looked at the heart. We've swung down to the IVC. We see a big, fat, plump IVC. We think this patient is volume overloaded. Even though their blood pressure is soft, they're not perfusing well. So we start the diuretics, but we do want to give something to support that blood pressure, to support that perfusion. What vasopressor should I be reaching for first? Is there an easy answer to this to say, just go for the norepinephrine, or is it a little bit more nuanced than that?
So it's usually right to go with norepinephrine first, because norepinephrine has both alpha and beta properties. Although the alpha properties predominate at the lower doses of norepinephrine, which is defined as less than 0.1 microgram per kilogram per minute, there is still some degree of beta effect even at the low doses. So I think norepinephrine would be a reasonable first choice when you're grabbing for a vasopressor, considering the easy availability of this medication in most emergency rooms.
I'm a big fan of epinephrine. This is one place where I don't like using epinephrine because it can cause some more tachycardia. It can cause some tachydysrhythmias, which is really going to make your cardiogenic shock worse. Phenylephrine definitely out here. There's really no effect on the contractility of the heart with that agent. So I agree. Norepi is the first one that I'm going to be reaching for. But it brings up the issue of when do I add that inotrope? So if the patient has that soft blood pressure, I start my norepinephrine. If the norepinephrine works and the pressure looks good, do I need an inotrope at all? If the norepi is getting to higher doses, should I be reaching for another vasopressor, or is that where I should add my inotrope? What's your trigger here?
So what I usually would tell people is that to watch the dose of norepinephrine, I would say that a good dose, a good moderate dose of this medication is 0.2 micrograms per kilogram per minute. If you are not able to stabilize the circulation at 0.2 micrograms per kilogram per minute, then you need to think twice, think 3 times, think 4 times. Maybe we need a better agent. And what I usually would do at this time is recheck the lactic acid level. If the lactic acid level continues to rise, then maybe it's time to start an inotropic agent. And I get concerned, like the lights and sirens all fire up when I see a lactic acid more than 4. Lactic acid more than 2, that's still low level elevated, but more than 4, we need to think twice and let's get this lactate down. The usual agent that I would go for in this situation is dobutamine. It works quick, and I usually start at 2.5 micrograms per kilogram per minute, and it is a more potent inotrope than just using Levophed alone.
Well, that's great. And we like to keep it a little simple for us in the emergency department when we're dealing with all these different things. So start your norepinephrine first, recheck a lactate. You can re-look at your echo, reassess the patient. If they're not improving with that, come in with the inotrope. Dobutamine is going to be your go-to first-line agent. Yes, there are other agents out there that are inotropes, but dobutamine we're very comfortable with in the emergency department. So that's a nice place to start. I've hopefully gotten you and your team down at this point, but for those people who are either not working at Staten Island or somewhere else, what are the other measures that either we can do, or more importantly, our cardiogenic shock team or our cardiology team can help the patient out with? We've added the inotrope. We've already started that vasoactive substance. We've given them diuretics. What else can you offer to the patient that may be a little bit beyond the scope of practice for an emergency physician or emergency clinician?
Yeah, so you've started these treatments, but the other thing too is we have to think about the airway of the patient too. Most of these patients have like pulmonary edema in the setting of cardiogenic shock. So we need a way to move the fluid out of the lungs. So what we would usually see is that these people are started on positive pressure, usually with BiPAP, to help with the pulmonary edema. And hopefully by that time, once you've called the cardiogenic shock team, that they've come to the emergency room to assess the patient and to assess for candidacy for even more advanced therapies, which include machines. We are now in an area that we could do various types of heart pumps to support the heart instead of using high doses of medications, because studies time and again have shown that instead of going on 2 or 3 inotropes, it would be better to go on machines in certain cases.
And what machines are we talking about here? I know when I was training, it was intra-aortic balloon pumps. Those have started to fall by the wayside. We have other devices that we can use here. What is our team typically reaching for in this particular circumstance?
So what we typically reach for here at our hospital is an axial pump called an Impella CP. So an Impella CP is a pump that goes to the groin that sucks blood from the left ventricle and expels it into the aorta close to where the coronary arteries are. And with this machine, we can provide up to 2.5 liters per minute of cardiac output. There are even larger Impellas, and our most advanced option available at our hospital is veno-arterial ECMO, wherein we support the heart and the lungs completely through an external machine.
And those devices can be bridges to things like LVADs. They can even be bridges to cardiac transplant, depending on where the patient is. It's really going to be something that obviously we're not doing in the emergency department, but it's good to know what is next down the line for your patient. I want to shift a little bit, Martin, here, away from the patient who has a primary ischemic issue to their heart and is in cardiogenic shock. They have underlying CHF and they're in cardiogenic shock, to something that we saw quite a bit during COVID. We obviously saw it in the past, which is viral myocarditis causing cardiogenic shock. And this often happens in pretty young patients. And I guess when we look at all of these different modalities that we've discussed, does anything change in that subset of patients? So let's say that I have a 20-year-old who's got a preceding viral illness. Now they come in shocky. We do all of these different measures and we realize that they are poorly perfused, their extremities are cold, their cardiac function looks terrible, and we are suspecting viral myocarditis. Am I bringing the same management for that patient, or does it change what I should be administering?
So that's a very good question, because we are about to head into flu season, and flu by itself can cause viral myocarditis. So these younger patients who develop a viral myocarditis picture of cardiogenic shock need to be taken to the cath lab right away. The reason being is that these are the types of patients that may benefit from an endomyocardial biopsy, because there's an entity called giant cell myocarditis that responds to high doses of steroids, like a gram of solumedrol. So that's the difference in types of pictures. Other than using machines and medications, steroids may be helpful to a small subset of patients with viral myocarditis. And another common type of myocarditis seen now with the newer types of chemotherapy that we are giving. So some of these tyrosine kinase inhibitors that modern day cancer patients are receiving can cause checkpoint inhibitor myocarditis of the heart, which behaves like viral myocarditis and also has to be treated with high dose corticosteroid therapy.
So these are good triggers for us to keep in our mind, especially as we're heading into those winter months. And you're right, as these MABs become much more commonly used in cancer patients, we have to be aware that they can basically cause an itis to any organ, and the heart is no exception. So we should be thinking about this in patients who previously had relatively normal cardiac function and now are coming in with what looks like cardiogenic shock. Again, young patients with viral syndromes who come in shocky, we have to think about this disorder, especially because we don't typically trigger our cardiac shock team in those patients. We're thinking sepsis, we're pushing sepsis, we're sending them to the MICU, but getting those cardiac services involved early can really change the trajectory for the patient and what we can do to help them out. Let's shift again, because we mentioned sepsis a couple of times, and we know that cardiomyopathy in sepsis is a real entity. Even in patients who prior had normal cardiac function, they can have a cardiomyopathy from sepsis. This can be difficult to identify because oftentimes when they're hypotensive, you look at their heart and that left ventricle is just banging away. It looks great. because they have no peripheral vascular resistance. Then you start your norepinephrine, you start to clamp down. And if you take another look at the heart, you'll see that that LV is not functioning quite as well as it was before. I understand that most of the time you're getting these consults from the MICU, but as we become better and better with ultrasound, more savvy with those findings, we are going to identify these patients. What should we be doing for management in this group of patients? So this is the patient with sepsis who we think has cardiomyopathy from that sepsis.
Yeah, so that's a good question. So since this is a very common occurrence, like people with even like preceding congestive heart failure who develop sepsis, how do you deal with pictures like this, and how do you know if it's cardiogenic now predominating over the sepsis? So how we do this is through a blood test called the mixed venous. So most of our patients with cardiogenic shock will already have central lines that are going to their neck. And these central lines usually sit in the plane of the superior vena cava in the right atrium. So in invasive cardiology, our gold standard for measuring central tissue perfusion is a number called mixed venous. The mixed venous is the coalescence of the multiple venous drainages of the body. The SVC covering the brain and the organs atop, the IVC covering the organs below, and the coronary sinus covering the coronary arteries and the heart. So the greatest contributor of all of these three is the superior vena cava, because the SVC accounts for the oxygen utilization of the brain, which is the body's greatest oxygen utilizing organ. So if we had a catheter in the superior vena cava or in the right atrium, which is our usual central line, we could check a central venous oxygen saturation from this number. And if this number is low, the normal value is around 70. And if this number is low, like 40s, 50s, then that should raise red flags in our head that maybe instead of adding more pressors, what we need to do is come down on the pressors and probably add dobutamine or vasodilators to the patient's current regimen.
All right, a lot of really helpful tips in there. And I think we have gotten away from sending those central venous oxygen saturations as opposed to what it used to be when I was in training. But this is a specific circumstance where that value can be very helpful. So we shouldn't throw out the baby with the bathwater. We have to remember that there is a role for getting these extra measures that can really tip us and help us to properly manage that patient in front of us. Martin, I want to pivot one more time to another topic that comes up quite often in patients with cardiogenic shock, which is dysrhythmias, specifically atrial fibrillation. So the patient might have chronic atrial fibrillation, and now they have AFib with RVR. Sometimes they don't have chronic AFib, that actually the cardiogenic shock sets them off, or the AFib sets off the cardiogenic shock. Always hard to know exactly what's going on. But if you have that patient with cardiogenic shock, with AFib with RVR, and you think that the rate is contributing to that cardiogenic shock, what should we be doing to control that rate? Should we be using our typical beta blocker, calcium channel blockers, or is there a little bit more nuance to that?
So in this particular scenario, we have to recognize what other medications the patient is on. So by this time, the patient's already on some dose of Levophed and some dose of dobutamine. As a result of this scenario, we are not allowed to give the patient beta blockers or calcium channel blockers because they go against the other medications that we are giving the patient. So this is the situation we're in. Two things may be considered. So as far as medications, the first one is amiodarone. I know we are all afraid about the side effects of amiodarone and the risk of conversion, but it is technically the safest one to use in the setting of active sepsis. So you give a 150 milligram bolus followed by the usual infusion of 1 milligram per minute for 6 hours and 0.5 milligrams per minute for the next 18 hours. The other medication that we need to be entertaining in this situation is digoxin. Loading these people with digoxin, sometimes in concert with amiodarone, has a very good effect of slowing down the AFib and even converting it to sinus rhythm. So we need to always anticoagulate this patient, especially if their CHADS VAS score is more than 2, given the small risk of stroke when we cardiovert these patients. The other thing that I would like to raise, though, in this situation is the importance of the atrial kick. So these people with limited reserve, they are dependent on the atrial kick. And when they go into atrial fibrillation, they lose as much as 20% of their cardiac output. So I always tell the house staff when they're with me in the CCU that everyone deserves the benefit of sinus rhythm. Because why are we depriving these people of the 20% of cardiac output that the atrial kick provides? So I think these things, knowing when to cardiovert, knowing when to go for amio and dig, is a fundamental skill in treating these mixed scenarios.
In my mind, when I look at these patients with AFib, and I love cardioverting patients, but if they have chronic AFib, now they're coming in decompensating, there's probably not enough electricity in the hospital for me to convert them externally. So I'm not really going to rely on being able to cardiovert those patients. If they're a new onset, sure, I'm going to cardiovert them because I have a much better chance of getting them out of that rhythm. And again, this is where amiodarone and digoxin can be really helpful, is in that chronic AFib patient where we want to control that rate. Amio and digoxin can, both of those agents can do that. Digoxin might even give a little bit more contractility, but is that chronic group that is much more difficult to manage, where electricity is just really not going to be the hero. And sometimes we waste a lot of time trying to ratchet up the energy and get that patient out of AFib when they've been in AFib for 30 years. We ain't going to fix it in the emergency department in that moment. And so we have to think about those other agents and whether we should be using those instead. I think those are great tips for managing a very difficult patient population. And Martin, we have covered a ton of stuff here. I know that you have so much more to offer, and that's why we have your team available to us when we need help. I would put a little bit of a plea out to my colleagues in the emergency department of, if you think it's cardiogenic shock, give the team a call. Let them come down, help out. First of all, because you can learn what they're doing to diagnose that patient with cardiogenic shock and then move forward. Maybe they're going to come down and say, no, this isn't cardiogenic shock. We don't think we have much of a role here. That's great, because then we can pick their brain and say, well, why not? What was I looking at that I thought it was, and you're seeing that it isn't? But I think this can really help us to up our skill set, remembering that many places we go to work, I'm not going to have Martin and his team available to me. So I need to learn those skills, incorporate them into what I do. So we should use the team when we are suspicious, get those experts down to the bedside to help us to best manage that patient. And I think if we bring all of these things together, Martin, we can really identify these cardiogenic shock patients early, and then we can make sure to treat them appropriately. And that's really the crux of the matter here. I don't think there's a lot of issue with getting the treatment done. A lot of it is with making sure that that's actually what we're dealing with, instead of the more common things like septic shock. So Martin, thank you so much for doing this. I can't wait to have you back on the podcast to talk more about all of these different cardiac issues.
Thank you for inviting me, and it was a pleasure sharing my expertise on the matter. So when in doubt about cardiogenic shock, just call the shock team. We're here available for you 24/7. Thank you.
I love that message. Love it. All right, Martin, take care, and we'll talk to you soon.